Dr. Iswanto Sucandy. I'm a hepatobiliary surgeon at AdventHealth Tampa. Thank you for joining us for this online CME. I will be sharing with you today about the treatment of colorectal liver metastasis and hepatocellular carcinoma, which are the two most common cancer of the liver. When we talk about liver cancer, there are two main types of liver cancer. The first one is called primary liver cancer. The second one is called metastatic liver cancer. Primary liver cancer means the tumor starts in the liver and grow in the liver. The most common is HCC, hepatocellular carcinoma. Second most common, but now is also increasing in frequency, is called intrahepatic cholangiocarcinoma. This is a bile duct cancer that occurs from the biliary branches within the liver. The third is liver sarcoma, is way less common compared to the first two. And I place a gallbladder cancer in parentheses because the gallbladder cancer also requires liver resection, and they start from the gallbladder, which is attached to the liver. The second type of liver cancer is metastatic liver cancer. Some people call it secondary liver cancer. The most common is obviously colon and rectal cancer. We call it colorectal liver metastasis, CLM. The second most common is a neuroendocrine tumor that metastasizes to the liver, that can come from the pancreas, small bowel, large bowel, rectum, even a respiratory tract, GIST tumor, usually from the stomach. They can metastasize to the liver as well, breast cancer, bowel cancer, extremity sarcoma, arm, leg sarcoma can go to the liver, melanoma, GU tumors, ovarian cancer, kidney cancer, bladder cancer. They are all well known to cause metastasis to the liver. I'm going to start with the most common liver tumor, which is the colorectal liver metastasis in the US. If you can see the diagram on the left side of the screen, there is a malignant tumor in the sigmoid colon that basically send tumor cells through the mesenteric veins. Mesenteric veins all go to the liver. Now the tumor cells is flowing into the liver, they get stuck in the liver, they grow in the liver. So now the patient has a metastasis in the liver of the sigmoid colon cancer. And they can look like this on the laparoscopic view. They look hard, white, they're indurated, they're raised. And this is quite typical for metastatic adenocarcinoma to the liver. Colorectal cancer is the third most common cancer in the US. 50% of colorectal cancer will end up with liver metastasis. Either they're diagnosed at the same time of the colon cancer, called synchronous, or they occur in the different time of the colon cancer, is called metachronous. However, half of them will develop liver metastasis. The good thing is liver is the only site of metastasis in about 40% of patients. Complete surgical resection to achieve R0 oncologic margins means all the tumor removed, no evidence of tumor left behind, is the only primary curative option for patient. Complete ablation is a secondary alternative for patient that cannot undergo a liver resection. At this point, liver transplantation is not an option for colorectal liver metastasis because the metastatic nature of this disease. Unresectable patients have a poor outcomes. 5-year survival of 0%. It means the patient with liver metastasis from colorectal cancer, pretty much none of them will pass 5 years of survival. They all die within 5 years. Liver resection in combination with chemotherapy is the standard of care for resectable patient. Why it becomes standard of care? Because the liver resection, in addition to chemotherapy, increases the 5-year overall survival from 0% to 60%. You can see here, 5-year survival, 60%. So if we ask the patient, do you want to live in 5 years? Do you want to have 0% survival or 60% survival? And this is obviously a very easy question for the patient to answer. Obviously, they want to live at 5 years, and they have 60% of being alive 5 years if they have proper treatment with liver resection and chemotherapy. Now, from historical perspective, open liver resection hepatectomy in the 1970 or 1980 resulted in 20% mortality. 1 out of 5 patients dies from the operation. However, now it's only about 0.3% of patients dies from the operation. So the operation become very safe, and the outcome much improved with the modern liver surgery. The improvement in outcome is because there is advancement in knowledge of the surgeon. There's a better instrumentation to the liver surgery, and also critical care to manage the patient post-liver surgery also much better. And now we even have minimally invasive technique options to even be safer than the open liver surgery. The outcome is better with minimally invasive technique. I want to share with you a simple graph here. However, it's very informative. You can see the first line here. This is the patient survival with surgery and chemotherapy. If you see here 60 months, between 5 years, we draw a line here. Surgery and chemotherapy will give about 50 to 60% overall survival. The second line is the patient with chemotherapy only. At 60 months, 5 years, the overall survival is about 5%. So most patients died. The third line is the patient who did not get any treatment, no chemotherapy, no surgery, nothing, basically supportive management. They barely passed 3 years. So obviously the best management for the patient is the first listed here, surgery and chemotherapy. What are the preoperative preparation for liver resection? The first is to obtain a good imaging. The good imaging means a liver CT scan with a thin cut. Some patients cannot undergo a liver CT scan. They can undergo liver MRI, which also serve the same purpose. They need a laboratory workup. They need the liver function test checked. They need the coagulation panel checked. Liver biopsy is only indicated if the CT scan or MRI is not clear. What I mean by that, not everybody needs liver biopsy. In the community, there is a tendency that as soon as a doctor sees a liver tumor, they always want to biopsy it. This is actually not a recommended practice. The liver biopsy is only needed for selective cases that is inconclusive after CT scan or MRI. Can be done percutaneously or also can be done endoscopically. Again, it is very important to understand the liver anatomy for the surgeons to be able to do safe liver surgery. Liver is a complex organ, and it is not easy to see the intrahepatic vessels within the liver parenchyma. So it is important to have an expert performing the operation. There are 3 ways of doing a liver resection. The first is the traditional open operation. The second is what we call minimally invasive approach through a laparoscopic or robotic approach. The third is a hybrid. It's a combination between the open and minimal invasive. It's done in several centers. However, in our center, we do open liver resection in about 20% of the time, and we do a robotic liver resection about 80% of the time. Minimal invasive approach is obviously the best approach if technically feasible and the surgeon has the expertise to do it. This is the comparison between open liver resection and robotic liver resection. As you can see, with open operation, we create a wide incision in order to expose the liver. This is the retractor to keep the abdominal cavity open. While on the right-hand side, you can see several pictures, several trocars that was made to enable a robotic liver resection. It's about 1, 2, 3, 4, 5, 6 trocars. Each of them is about 8 millimeters in size, and this is the largest incision where the liver specimen has to come out. So the same operation can be done, big operation or small operation. We like to do a small operation if possible because it's better for the patient. Why minimal invasive surgery is better? There have been many publications that have compared minimal invasive versus open liver surgery for colorectal liver metastasis. Minimal invasive surgery results in a lower blood loss because it's a more delicate operation. Therefore, the patient needs less blood transfusion. They can resume oral intake. In fact, they can drink the same day of the operation. If the operation is done at 11 o'clock in the morning, for example, patient should be ready to drink water at about 2 or 3 o'clock in the afternoon. Minimal invasive operation, because of the small incision, they require less pain medication. Patients stay in the hospital much shorter, and wound complications also less because the small incision infection rate is much less. Hernia rate is also less. Cosmesis is better, and they have a comparable or potentially better oncologic outcome with the minimal invasive operation, if possible. This is the first randomized trial from Norway that compares minimal invasive versus open liver operation. The outcome of the study was minimal invasive operation is associated with a lower 30-day complication rate, shorter length of stay, and less narcotic pain medication requirements, and all of these were significant statistically. So whenever feasible, minimal invasive approach should be favored over open approach. However, in about 15 to 20% of patients still require open operation due to the tumor size or complexity. How about oncologic outcome? There used to be a long-standing, very heated debate among liver surgeons to see whether minimal invasive will or can produce outcome as good as open operation. The answer is yes. These two lines is representing minimal invasive liver operation versus open operation, and those two lines are basically superimposing on each other. It means the oncologic outcome, this is at 3 years, is 36 months, this is 5 years, 60 months. The oncologic outcome is good. So minimal invasive operation is as clean as open operation. Now, patient has to be assessed whether they are candidates for minimal invasive liver resection. The indication that do not change. It means if the patient is unresectable from the perspective of open operation, it means they're also not resectable from the perspective of minimal invasive operation. For example, patient with colon cancer with liver metastasis, however, they have brain metastasis, then those patients are not candidates for resection either by robotic or open. As I mentioned before, they need to have a CT scan or MRI, preoperatively, liver biopsy only selectively. And now this is the most important thing. What are the factors that tells the surgeon whether the patient can be given a minimal invasive hepatic resection or liver resection or not? Tumor location, tumor size, the distance to the vital structures, and experience of the surgical team. At least in our program, tumor that is located in the central part of the liver, very close to the major vascular structures feeding the liver, very close to the biliary system that drain the liver, that operation needs to be done open. Tumor size. If the tumor is approximately 20 centimeters in size, that operation should probably be done open because it is quite difficult to flip the tumor back and forth by robot or laparoscopy, and it is safer not to fracture the liver by doing an open operation. Distant or vicinity to the vital structure. For example, if the tumor is invading the vena cava or the major vascular structure that bring blood from the bowel, from the leg toward the heart. If we know from the get-go that the patient needs a reconstruction of the vena cava, that operation should be done open to enable a vascular reconstruction to be safely done with open approach. This is a liver cystic tumor from our own operating room that was removed by the robotic approach. The patient is cured from this liver tumor and she's doing very well. Again, each of the liver tumor which was resected from a patient, we send them for intraoperative forceps section to make sure the margins of resections are actually clean from the tumor. What I mean by margin resection is this. We can see here there's a liver tumor in the center of the specimen. Margin means the distance between the edge of the tumor to the edge of the liver. So this patient has a very good margin. This is at least a centimeter margin of normal liver parenchyma. This ensures us that the patient have a clean operative resection. I'm going to play you a video of a minor liver resection for a colorectal cancer liver metastasis. You can see the robotic arms is cutting through the liver with very minimal blood loss. There is a fear out there that the liver resection is a very bloody operation. In some sense, it's true. However, with the proper technique, the liver operation can be done as bloodless as possible. So the specimen is placed in a small laparoscopic endobag, like fishing a fish. You can see the tumors right here. The tumor is removed now with the part of the liver and is ready to be taken out of the abdomen and sent to pathology for frozen section. Now, in our program, it is becoming more common now that we combine both liver operation and the colon operation at the same time. For example, a patient who was diagnosed to have a sigmoid colon cancer and a tumor in the liver. Obviously, the traditional way of treating this patient is by doing two separate operations. They usually undergo first a colon operation, recover. A month later, they undergo a liver operation, recover, and then followed by systemic chemotherapy. Now, in our program in AdventHealth Tampa, what we're doing is we're trying to do a minimally invasive surgery for both the colon and the liver at the same time. So this patient will have a single operation instead of two. The patient will have a single post-operative recovery instead of two. The patient will have an earlier initiation of adjuvant systemic chemotherapy instead of waiting of at least a month of each operation. Patient only needs a month of time after the operation. And by initiating the adjuvant chemotherapy earlier, we expect a better clinical and oncologic outcome for the patient. This is a paper, a journal article that we published in American Surgeon Journal about our experience of doing a minimally invasive colon and liver resection at the same time. And this is obviously beneficial for the patient. Now, I want to switch gear a bit to discuss about the second most common liver tumor in the United States, which is a hepatocellular carcinoma. You can see here the liver tumor is seen in the center of this screen. Hepatocellular carcinoma. This is the most common primary liver cancer. Primary means it starts from the liver and grows in the liver. It is about 80 to 90% of primary liver cancer worldwide. It is the fifth most common cancer with more than 500,000 cases per year. There are three types of curative treatment for this type of cancer. The first one is a liver transplantation. However, patients have to meet a Milan criteria, which is quite strict for liver transplantation. Many patients do not meet Milan criteria. It means they cannot undergo liver transplantation. The second way of treating hepatocellular carcinoma, which is the most common way, is a liver resection. It can be done open or minimally invasive approach. The third is local ablation with a radiofrequency ablation or microablation. For a patient with a preserved liver function, liver resection is the preferred way of managing liver HCC cancer. This is a schematic picture of a treatment algorithm of HCC. I want to point out to you that there are only three types of treatment that are considered curative. They are liver resection, liver transplantation, and this is ablation. And you can see here, curative treatment can only be given in about 20 to 30% of patients. However, those patients who underwent curative treatment, the 5-year survival is about 50 to 70%. Now, if we compare the curative treatment to a palliative treatment, in palliative treatment, the three-year overall survival is only 10 to 40%. What are the palliative treatment? This is the transarterial chemoembolization, Y90, Searsphere, Theraphere. They are all considered palliative treatment. Treatment with Nexafar or oral chemotherapy pill are also considered palliative treatment. So the conclusion of this slides is whenever somebody is a candidate for curative treatment, they should be referred for a curative treatment. They should not be referred for palliative treatment when they can be cured. Why? Because the 5-year survival is different. The survival is much better with curative treatment. either resection, transplant, or ablation. Ablation have limitation with the tumor size, and sometimes it is issue with the access to get to the tumor safely. We will talk about liver ablation a bit more in the later part of this talk. This is a survival of patients with surgery and without surgery for curable HCC. With surgical treatment, the median survival is 48 months. With no surgery, 8 months. So it's very clear that the patient should be referred for a surgical resection to a liver surgeon whenever they are resectable. And even if the doctor are not sure whether the patient is resectable or not, they should be sent for evaluation by the liver surgeon to determine whether they are surgical resectable or not. This is again a graph of a comparison between a curative treatment, which is the resection and ablation on those two lines above, and this is the palliative treatment with Y90 or chemoembolization, or BSC is basic supportive care, meaning not doing anything. The last two lines, they're actually not as good as the first two lines. So the survival is different. This is comparison between the liver and the liver resection here, the upper line, and the liver-directed treatment in the lower line. The survival is obviously much better with the liver resection whenever technically feasible. So now we discuss about two ways of doing a liver resection for hepatocarcinoma: open and minimal invasive. In our program, we do it robotically. So now you can see the lines of open and robotic operation for hepatocellular. Basically, they are just as good in producing a long-term survival outcome. They are not different. Therefore, either they have an open operation or robotic operation. From the oncologic perspective, they can achieve similar long-term outcome. I've heard from patients that they have a lot of concern that if the operation is done robotically, the tumor will recur much earlier. The surgeon will miss the tumor, and the cutting of the tumor is not as clean. And obviously, all of those mentioned above are not true with the scientific data proof. This is our team at the AdventHealth Tampa or hepatobiliary surgery. I want to switch gear with you to talk about the liver ablation for liver cancer. We also perform liver ablation routinely in our operating room under ultrasonic guidance laparoscopically. There are two ways of doing ablation. The older way of doing ablation is with radiofrequency energy. The more modern way is using microablation. In our program, we use microablation. The ablation is used for patients who are not candidates for liver resection, or sometimes in addition to liver resection. For example, if the patient has advanced liver cirrhosis, they're not candidates for transplant, they're not candidates for liver resection, and those patients should be served with liver ablation. What I mean by in addition to liver resection, many times we take patients in the operating room, they have multiple tumors. The largest liver tumor gets resected, and the smaller liver tumor get ablated. And the reason why the smaller liver tumor get ablated, because the surgeon is trying to preserve as much as liver parenchyma as possible. The principle of modern liver surgery is to try to accomplish the liver surgery as clean as possible. However, we try to preserve as much as healthy liver part as possible. So instead of removing too much liver, a tumor that is less than 3 centimeters at the time of operation can be managed with local ablation only. And when it's done well, the outcome will be similar as the liver resection. It is very important to realize that complete ablation should only be done for tumor about 3 centimeters or less. Larger tumor should be considered very selectively for ablation because larger tumor has much higher chance of local recurrence. This is what I mentioned earlier about the combination of liver resection and ablation for multiple tumors. In this picture here, the patient presents with 3 liver tumors. The way we will handle this situation or scenario like this is this liver tumor here on the left side is resected by local resection. The second liver tumor here is resected by local resection. And the third tumor, instead of being resected, is now ablated. By ablating this liver tumor, we can preserve as much as liver parenchyma around the tumor as possible so that the patient can live with much as liver parenchyma without tumor as possible. So parenchyma sparing liver surgery is the way to go. This is how the liver ablation work. This is the liver ablation probe. The heat energy is being produced from the tip of the needle ablation probe, and this is the area that will be ablated by the energy. So if there's a tumor here, the tumor will be killed by the heat energy coming from the tip of the needle. You can see here, this is the ultrasonic picture of liver ablation being performed. You can see here, this is where the liver tumor is located. Now the surgeon is under ultrasound, place the liver needle probe into the liver tumor, and then once the position of the liver ablation probe is confirmed to be adequate, then we start the ablation process. And you can see here the liver tumor that is being ablated now start to change shape and density. It means they're being eliminated by the heat energy. The beauty of doing this under ultrasonic guidance is you can actually see how the liver ablation is being done. We can make sure that the tip of the needle is actually perfectly placed within the liver tumor. This is a graph of survival. Tumor size that is less than 3 centimeters, it means smaller tumor, is represented by the upper line. The smaller tumor has a better overall survival. The larger tumor has a poor survival, worse survival with ablation, because the larger tumor tend to recur more than the smaller liver tumor. In our program, we perform routine robotic minimal invasive liver resection. Our program formally started in 2017. At this current time, we have undertaken more than 200 robotic liver resections. This is not including patients with liver ablations or hepatic cyst resection. We utilize the XI robotic system, the newest version of the robotic system. We also a part of national US and Canada North American Liver Registry clinical outcome study. We follow our outcome very closely, so we exactly know the outcome of each patient. And in our program, as I mentioned before, patients who have involvement of the vessels, especially the large vessel, hepatic vein, vena cava, aorta, we do this open. Patient with the portal vein involvement, we do it open. We are the only program in South Florida that offer major robotic minimal invasive liver resection at this point. We have published many papers on the technique of robotic liver resection as well as outcome of robotic liver resection in multiple scientific journal in American Surgery. This is one of the latest paper that we published on robotic segment 1 liver resection. We have probably 5 or 6 more papers after this one that was published for the knowledge to be disseminated and somebody else to learn how to do minimal invasive liver surgery. I want to show you a video of how we do a liver resection removing liver cancer. This is the patient with neuroendocrine tumor on the right side of the liver. We always start the operation by checking all the lymph nodes. We resect those lymph nodes. We send them for first resection. This is myself sitting at a consult. We isolate the vessels that bring blood to the liver. The liver has dual blood supply, so the liver has 2 vessels that bring blood to the liver. We utilize, this is called intraoperative liver ultrasound. This is an ultrasonic device that we utilize to map where the location of the liver tumor as well as the border of the liver tumor. You can see here, we utilize the robotic instrument to do this liver operation. We place a stitch to gain traction of the liver. When we split the liver, this is the line of liver resection. This is the normal liver on the left. This is the tumorous liver on the right. We place a small clamp to temporarily stop the blood supply going into the liver. So when we cut the liver, it does not give us too much bleeding. This is the bile duct being stapled with the laparoscopic stapler instrument. You can see here on the left side, as I mentioned before, this is the part of the liver that has tumor in it. So we cut the liver. You can see it's quite a bloodless operation. This is again a small laparoscopic endobag that we insert into the abdomen to remove this cancerous part of the liver that needs to be sent to pathology for frozen section and permanent section. And this is the part of the normal liver that will stay. I would like to mention also that the liver is the only organ that can regenerate. This is a very common question that I hear from patients. What happened with the remaining part of my liver? The answer to the question is the remaining part of your liver will regenerate. It means it will grow back to achieve approximately 95% of the original liver volume within 3 to 4 weeks. So this is actually a very short time that the liver are required to regenerate. And we learn this by doing a liver transplantation, living donor. We learn this by doing a 2-stage ALPS procedure in our program. We watch the liver grow week by week. So this is why I can tell you that the liver will hit almost the original volume within about 4 weeks after a major liver resection. This is how the specimen looks like. This is approximately a 12 centimeter specimen containing liver tumor that was able to be removed with small incision by robot. This is a second video of left liver resection for a bile duct cancer. You can see here, this is a picture of intraoperative ERCP. I was called by one of the gastroenterologists doing ERCP, during the ERCP. This is the bile duct that is opacified by the contrast injection. Now this is segment 2. This is called segment 2, bile duct. There is an obstruction in the origin of segment 2 bile duct. Now, whenever we see an obstruction within the bile duct, the first thing that we think of are intrahepatic, early stage intrahepatic cholangiocarcinoma. This is about to become a bad cancer. So a hepatobiliary surgeon was consulted for management of this patient with working diagnosis of intrahepatic cholangiocarcinoma. Again, we utilize the robotic system, some adhesions or scar tissues to the liver was freed up. You see here, this is a little lymph node here. We always sample those lymph nodes. This is important for the oncologic information. This is the what we call left hepatic artery being divided. This is the pole vein being divided. These are the 2 blood vessels that carry blood to the left side of the liver. I mentioned before, liver has 2 blood supplies. We put a silk suture to take down the inflow to the left flow of the liver. Now again, this is intraoperative liver ultrasound being utilized to check the border of the lesion to make sure we completely resect this tumor. Now, with the robotic instrument, we cut the liver. This is a bloodless operation. This is a laparoscopic stapler that we use to transect the bile duct intrahepatically. And you can see here, this is the last part of the operation, which is the stapling of the left hepatic vein. This whole operation, removing the left side of the liver, which is about 45% of the liver, only took about 1 hour and 45 minutes. And this is all done minimally invasively with 5 small incisions. If we do this open operation, this operation will take probably about 2.5 hours or 3 hours, and the patient will stay longer in the hospital. This patient specifically that underwent this operation, left liver resection robotically, she drank liquids about 3 hours after the operation. The next day We advanced the diet to full liquid diet. Full liquid diet means potato soup, mushroom soup, something with more substance, and she left the hospital in about day 3 without any complications. We did not pollute drain in our program when we do major liver resection. We do not place drain anymore. In the first 50 cases that we do, we sometimes place a drain. Now we can say we have done over 200 liver operations, including major ones. We know enough that a patient with a good liver operation do not need drain postoperatively. This is last part of my slides. This is a technique of 2-stage liver resection for multiple bilateral liver tumors. When I came to Tampa, I heard from many medical oncologists said, if the patient have bilateral liver tumor from colorectal cancer, it means they are unresectable. This is absolutely not true. In fact, most patients with liver metastasis from especially colon cancer or neuroendocrine tumor or ovarian cancer, bladder cancer, kidney cancer, many of them actually have multiple bilateral liver tumor. Those patients are not necessarily unresectable. They can be easily resectable. This is what I mean. Patient with multifocal bilateral liver tumor, they obviously require a major extensive liver operation. However, there are ways of making this operation safer. We, in our program, we have performed what we call 2-stage liver resection. I'm going to use the image on the lower part of the slides. You can see, if you can look at this picture carefully, the patient have liver tumor here, 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 here. Okay, so this patient have multiple bilateral liver tumor. In order for the patient to be resectable, the patient will require a 2-stage operation. This is called stage 1 and stage 2. So for stage 1 of the operation, we take the patient to the operating room using robotic approach. We resect, locally resect this small liver tumor here, small liver tumor here. We resect them and we clean the left side of the liver. This is clean now after we resect this and this. Now, in addition to doing that, we also do a portal vein ligation. So we put a clip or suture on this part of the vein that bring blood to the tumorous part of the liver. By doing that, all the blood has to go to the left side of the liver. So this part of the liver will grow, will hypertrophy. And this part of the liver will shrink, will atrophy. This is the part of the liver that has tumor, so we don't need this part. In addition to portal vein ligation, we also split the tumor, the liver. So we disconnect the tumorous part of the liver from the normal part of the liver now. So we split this liver in two. Approximately 14 days later, this left side of the liver will grow, will increase volume to approximately 30% or less. And this is why I mentioned earlier, we can tell how fast the liver will hypertrophy by doing this operation. So after 14 days or so, we obtain another CT scan to measure the volume of the liver that will be used for the liver remnant. Once we document on our volumetric 3-dimensional CT scan reconstruction that we do have in our program with TeraRecon imaging software, once we document that the patient has more than 30% of this future liver remnant, we go to the operating room for a stage 2 liver resection. By doing a stage 2 means we cut the tumor-bearing liver segment, which is the right part of the liver, and leave this with the patient. So after the liver resection, you can see here the right side of the liver is now missing. The patient only have the left side of the liver with appropriate blood supply to it. This is a very survivable, very doable situation. And in fact, this patient is cured. So after the second stage operation, the patient does not have any liver tumor anymore. The patient is considered tumor-free. And we do this more and more frequently now for a young patient with advanced multifocal bilateral tumor metastasis from colon cancer, neuroendocrine cancer, reproductive organ cancer metastasis to the liver. And also we do this operation also for a patient with a large hepatocellular carcinoma that are not a candidate for liver transplantation or not candidate for a simple right or left extended hepatectomy. So this is routinely offered in our program. Last part of the talk was about a NASH. So in our program, in collaboration with the hepatologists, we run a clinical trial of non-alcoholic steatohepatitis fatty liver disease. So this is what we call fatty liver disease. This is becoming more and more frequent in our society because of the obesity, and used to be alcohol drinking. Now obesity is becoming more frequent. So a lot of patients end up having fatty liver. And as we know, fatty liver is not good for liver for long term. Fatty liver will induce liver cirrhosis after 15 to 20 years down the road. Therefore, we're trying to find a cure for a fatty liver. And we have several agents that are under trial investigation to try to find the treatment for fatty liver disease. So our program is open for a trial for NASH in conjunction with our hepatologist. This is the conclusion of my talk on colorectal liver metastasis, hepatocellular carcinoma, liver ablation, two-stage radical liver surgery, ALPS, and finally our trial on fatty liver disease or NASH trial. I want to say thank you for your attention, and I would be happy to answer any questions either to email or phone calls or in person. Thank you very much.